So we can start now. Can you hear me, student?
Yes, sir.
Okay.
Yes, sir.
Good afternoon, sir.
Okay, good afternoon. Very good. So we will discuss about the introduction to brain, meninges, and CSF. So already CSF part you know better because in your class 12 it was taught. Only meninges and very brief about the brain. Okay. CSF also we will going to discuss. So objective is the anatomical classification of nervous system. We have to know the anatomical classification of nervous system, then different part of the nervous system, cavities within the brain and the spinal cord, then coverings of the brain and spinal cord. Spinal cord I will not going to discuss. Brain will only, I am confining with the brain. Then name of the different spaces between the coverings. Between the coverings means between the meninges and its clinical importance. Then CSF, formation, circulation, function and clinical importance. So nervous tissue already in histology you got. It is made up of neuron having the capacity of generating and conducting electric impulses from one point to other point of our body. Okay, so it is a tissue. What type of tissue? It is having capacity of generating and conducting electric impulses. So other tissue is having no property like this. Only in case of muscle, they are having the contractile, capacity of contractility. Then your generate as well as conducting impulses. So nervous system, it is made up of nervous tissue and we can classify it in two categories. One is physiological classification, one is anatomical classification. Physiological, under the heading of physiological classification, it is somatic nervous system and autonomic. Somatic means your body, which is supplying to the body wall, that is somatic. And autonomic, which supply the organ which are automatically controlled. Okay? We cannot control ourselves. It is automatically controlled, like heart, lung, GIT, etc. Anatomical means you're according to the location of the organ. It is not like that somatic nervous system is different and central nervous system is different. It is somatic, autonomic, same structures are within the anatomical classification also. Means anatomical CNS is not different, physiological CNS is not different. Okay, so according to their location, according to the location of the nervous tissue or the organ, okay, we can classify into two categories. One is central nervous system, one is peripheral. Central means the organ of CNS which lies at the center of the body or at the central axis. These are known as a central nervous system. Peripheral means they are supplying to the peripheral part. Now come to the your CNS. That is our main, I am confining within the anatomical part. Okay, anatomical, so central nervous system. So what are the parts of central nervous system? Brain. Again, brain consists of cerebrum, cerebellum, midbrain, pons, medulla oblongata. Last three structures, that is midbrain, pons and medulla, all together we call it as brain stem. While cerebrum is again having two lobes, or you can say two parts, right and left side. So it is known as a cerebral hemisphere. Cerebrum is equal to two cerebral hemisphere. Okay, two cerebral hemisphere, all together we call it as cerebrum. It is not a different structure. Cerebrum is equal to two cerebral hemisphere. Hemisphere means half. Then your spinal cord. Here you see all the structures are lying at the center. Your brain, it is located at the inside the cranial cavity. Then your brain, under the heading of brain, it is your cerebellum, cerebrum, midbrain, pons, medulla. Then spinal cord. Spinal cord is also at the central axis of our body. So all the structures are lying at the center. That is why it is your, according to our anatomical classification, it is called central nervous system. Peripheral nervous system. So it is going to the periphery. Periphery means part of our limbs, then body wall. So it is not at the center, but it is attached to the central nervous system. So peripheral nerves attached to the CNS or central nervous system, while they are supplying to the skin, muscle, joints, body wall, limbs, then visceral structures. Okay. Then classification of PNS, that is peripheral nerve. We can divide this peripheral nervous system into two. One is cranial nerve, one is spinal nerve. Cranial nerve attached to the brain. Some nerves are directly arising from the brain and supplying to our structures of head and neck mostly. Then our GIT also, then your thoracic organ also. So cranial nerve, so which are attached to the brain. So already we know what are the different parts of the brain: cerebrum, cerebellum, midbrain, pons, medulla. Then spinal nerve, they are attached to the spinal cord. Okay, spinal nerves are attached to the, then from the spinal cord, nerves are arising and they are going to the periphery to supply the different organ and to carry the impulses, sensory or impulses from the periphery to the central nervous system. Now come to two structures. One is gray matter, one is white matter. In your brain or in the CNS or in the nervous system as a whole, we are having two words. That is, one is gray matter, one is white matter. So gray matter, it is actually your cell body and dendrites. Because this cell body and dendrites of a neuron, they are having no myelin sheath. That is why color is gray. Okay, so it is not covered by myelin sheath. So lie at the center. In case of spinal cord, gray matter is situated at the center. In case of brainstem also, it is situated at the center. But in other parts of the brain, gray matter covers so gray matter is the outer area. Outer area of the brain is called gray matter, while inside the gray matter we are having the white matter. But in case of spinal cord and brainstem, it is just reverse. So gray matter will be at the center, at peripherally we are having the white matter. Which are, normally it is in case of spinal cord, all the white matters is made up of tract, spinothalamic tract, then tract of golden burdock, okay, pyramidal tract, that is your motor fiber. So fiber which are going from the brain, these are in the outer peripheral area. So at the center of the spinal, if you take a cross section of the spinal cord, then you can see that at the center of the spinal cord, we are having a gray matter. So gray matter means what? These are cell body and dendrites. Why it is gray? Because it is having no myelin sheath. Now come to white matter. So white matter, it is mainly axons. But it does not mean that only axons. Some part of the dendrite may be present also. Because there is a synapse between the dendrites and axons. So some part of the very small, negligible amount of dendrites may be present. Okay. So white matter, it is mainly made up of axons, which is covered by myelin sheath. That is why color is white. So we call it as white matter. In cerebrum and cerebellum, thin layer of gray matter present on the outer surface. Outer surface, that is called matter present on the surface, means outer surface. That is called cortex. Suppose in case you just in my head, your hairs are your gray matter. In case of cerebrum and cerebellum, and my scalp, apart from hair. So this scalp is made up of your white matter. So outer covering. So white matter, inside outer part, we are having a thin layer of your gray matter, and this is known as a cortex. Cortex, what we call cerebellar cortex, cerebral cortex, this is nothing but these are gray matter which lies outer to the white matter, because white matter is more, amount of white matter is more in brain and your so in brain means in cerebellum and cerebrum. White matter is more in comparison to the gray matter. So gray matter is the outer layer. nuclei. So this nuclei is nothing but these are the collection of gray matter. Collection of gray matter means cell bodies and dendrites. While it is inside the white matter of CNS. When it is inside, in case of CNS, collection of gray matter is called nuclei. But same thing, while it is in the PNS, we call it is ganglion. That is why spinal ganglion, dorsal root of spinal, dorsal ganglia of the spinal cord. You have got spinal sensory nerves, your motor, that is called posterior root, posterior from the posterior root. It is coming first your spinal nerve, sensory fibers will come, then your sensory fiber, what they will do? They will relay into the spinal ganglion. From the spinal ganglion, secondary neuron arises, which will ultimately enter into through the dorsal horn of the spinal cord and relay into the dorsal horn. Then there is a interneuron which is connecting your ventral horn. From the ventral horn, ultimately motor neuron arises. So that is the spinal reflex. You most probably have remembered that picture of spinal reflex. So nuclei is nothing but these are the collection of gray matter inside the white matter of CNS, central nervous system. While collection of gray matter in the peripheral nervous system, we call it is ganglion. That is your sympathetic ganglion, parasympathetic ganglion, ciliary ganglion. So there are so many ganglion. So it is in the PNS. If it is collection of gray matter in case of CNS, we call it is nuclei or nucleus, singular number. Now cavities within the brain and spinal cord. While brain is developing, actually it is from a tubular structure. It is not like our just what we are having the brain. It is not like cerebrum, cerebellum, midbrain, pons. It is nothing there. Only a single tube. Okay, like our heart. Heart is having a one tube now, originally. From that what will happen? That tube is gradually you're differentiating into different size and shape. The cranial part, it is more become enlarged. While it is more become enlarged, we call that a cerebrum. Okay, so while this tube is enlarging means around the tube, by the side of the tube, what will happen? Suppose this is a tube, and this tube is get dilated, and around the tube, outer to the tube, some structures will deposited. Neurons and dendrites, neurons are get deposited, migrated actually. Okay, then what will happen? Some cavity will be remain. So there is a two lateral ventricle. Lateral ventricle inside the two cerebral hemisphere. So we are having two cerebral hemisphere. So inside that cerebral hemisphere, we are having two lateral ventricle. One on the right side, one on the left side. Third ventricle, that is in the midline. In the midline, it is present, median cavity between two cerebral hemisphere. Between two cerebral. One is lateral ventricle is inside the cerebral. Suppose this is a one cerebral hemisphere. Inside that one cavity is there. This is your lateral ventricle because two on the lateral aspect, not in the midline. Second one, they are having the third ventricle. This is third ventricle. Okay, but this lateral ventricle is get communication with the third ventricle. So where is third ventricle? Between the two cerebral hemisphere. Then fourth ventricle. Fourth ventricle again it is your caudalie. Caudalie, there is a dorsal to medulla. Medulla and pons will lie anteriorly and posteriorly we are having the cerebral hemisphere. So suppose this is the pons and medulla and posteriorly we are having the cerebral hemisphere. In between that there is a space and that space is called fourth ventricle. And that finally this fourth ventricle is continuous downward as a central canal of the spinal cord. Now this entire ventricular system, it is lined by an epithelium which is called ependyma. So lining epithelium, it is having a specific name, ependyma. And these cavities, that is lateral ventricle, then third ventricle, then fourth ventricle, all these cavities are having a fluid. Otherwise what will happen? Cerebrum will get collapsed. Okay, so to maintain the contour of the cerebral hemisphere, inside that we are having some fluid. This is called CSF, cerebrospinal fluid, because it is also through the central canal, it is coming to the inside the spinal cord also. So CSF. cerebrospinal fluid. Now come to the brain. So during this development, what I have told, that is one tube. Now this tubular structure, when it is developing, it is divided into 5 continuous, but that tube is divided into 5 parts. From rostral or cranial to caudal, that cranial part is called telencephalon. Telencephalon here is ultimately give rise to our cerebrum. From the telencephalon, ultimately we got cerebrum. And become the cerebrum as large, it is called cerebral to cerebral hemisphere. Then diencephalon. Next part is diencephalon. Diencephalon consists of thalamus, hypothalamus. Diencephalon ultimately give rise to this structure: thalamus, hypothalamus, and other related structures related to thalamus and hypothalamus. Some nuclei are there, and is considered to the most rostral part of the brainstem. So brainstem, in the brainstem, that is rostral means your cranial part. In the brainstem, that means your first cerebrum, then we are having thalamus and hypothalamus, then we are having the brainstem. Okay, then we are having the brainstem. So mesencephalon, it is your midbrain, give rise to our midbrain. That is the first part of our brainstem. Here I have said brainstem is made up of midbrain, pons, medulla. So cerebrum, after the cerebrum, what we are having? We are having thalamus and hypothalamus. That is our diencephalon. Then our mesencephalon, that is our midbrain. That is the first part of the brainstem. So brainstem and the cerebrum, it is connecting by diencephalon. That is our thalamus and hypothalamus. Then we are having the metencephalon. That means this tube is divided. So metencephalon. This metencephalon part give rise to our cerebellum and pons. And this metencephalon ultimately it is having a carburetor. There is a one like our cardiac tube. Cardiac tube is also having looping. Na? So this here also some looping is formed. In the embryology part you can see. Then mesencephalon ultimately give rise to our medulla oblongata, which is the most caudal part of our brainstem. Then these ends at the level of the foramen magnum. Okay, foramen magnum is your opening at the occipital bone, through which ultimately at the level of the foramen magnum, medulla oblongata ends and our spinal cord starts. So this is the picture. So our cerebral hemisphere, that is our outer part. Then we are having the thalamus, hypothalamus, that is our part of your diencephalon. Then your mesencephalon is the midbrain, that is it is already shown. Then pons, it is the metencephalon part. Myelencephalon is our medulla oblongata. And posterior aspect is due to the looping, actually due to the formation of a loop in the cranial your neural tube, your cerebellum goes posteriorly. Then come to meninges. Meninges is the covering of your central nervous system, brain and the spinal cord. So brain and the spinal cord, it is surrounded by 3 layers of membranes, and they are known as a meninges. So here outer one, most outer one is called dura mater. Here you see the spelling mater, not T-T-E-R. It is T-E-R, M-A-T-E-R. So these your spelling you have to be careful. But here you see white matter, M-A-T-T-E-R, white matter, grey matter. So spelling. So you have to be careful. So dura mater. So dura mater is the outermost covering. Okay. So it is tough outer layer. Suppose you are wearing shirt. So shirt is your dura mater. Then if you are your undergarment, that inside the shirt, then that is your arachnoid mater. So arachnoid mater is delicate and it is middle layer. Then inner to that, pia mater. means your skin is your pyometer. So skin is intimately covered na our whole body. So like pyometer also intimately cover the surface of the brain. So it is just adhere to the brain structures. Okay, it adhere to the structures. But dura and arachnoid, it is not firmly adhere to the brain or adhere to the CNS. But pyometer, it is thickly adhere, firmly adhere to the structures of the brain. Okay, surface of the brain. Pia. Yeah? Then your arachnoid and pyometer, these two, it is altogether, these two, it is known as a leptomeninges. Leptomeninges, one is durameter is called Meninges. So here you see that outermost part is the skull. Then after that skull, there is a gray color structure. This is your durameter. Then dura, I have said in the dura and your next arachnoid. So arachnoid is it is our green color structure is arachnoid. Okay, outer green line is arachnoid. Outer green line is arachnoid. Then red line is our pyometer. So pyometer, then your pink color structure, this is our structures of our brain. That is your cortex, surface of our brain or central nervous system. So here you see red line is covering very intimately. So in between the red and the outer green line, that is our space. That space is called subarachnoid because it is beneath the arachnoid matter. So it is subarachnoid space. Again, between the dura is the outer, your gray color. So dura and your arachnoid matter, there is a space which is called subdural space. So it is beneath the dura. So shirt and your undergarment, that is the space which is called subdural space. Then your undergarment and the skin, this is your subarachnoid space. So in the subarachnoid space, actually we are having the CSF as well as we are having the blood vessels also. So one by one we will come. So come to cranial dura, means come to first durameter. Here in case of spinal cord, durameter is having a single layer. Okay. But in case of brain, inside the cranial cavity, this durameter is made up of two layers. One is outer dura and one is inner dura. Outer dura means it is called cranial. The durameter which is present inside the cranial cavity, we call it is cranial dura. While it is covering the spinal cord, we call it is spinal dura. What is the difference between cranial dura and spinal dura? Cranial dura is having two layers, while spinal dura is having single layer. Simple thing. That is why here in the picture you can see there at certain area these two layers, otherwise in the cranial dura I have said two layers, these two layers are intimately adhered, but at certain region they get dilated. There is a space, that is, it is shown as a blue color here, that is your intracranial venous structures or venous sinuses. We will come. So cranial durameter, it is thick, tough covering of the brain, consists of an outer layer. Outer layer is called periosteal layer because it covers the inner surface of the skull, while the bone is outer covering of the bone is called periosteum, while inner side covering it is called endosteum, because skull bone is having two layer, outer layer, inner layer. Yes, so outer layer it is called periosteum, and while it is inner layer, we call it is periosteal layer of cranial dura or endosteal layer or endocranium. So it intimately covers the inner surface of the skull bone. And another layer is inner meningeal layer, which actually covers our surface of brain. Okay. So outer periosteal layer, it is firmly attached to the skull. Already I have said, and is the periosteum of the cranial cavity. So continuous with the periosteum on the outer surface of the skull. Because in the outer surface of the skull also we are having a fibrous covering, that is periosteum. This periosteum and endosteum, they are continuous we add the foramen magnum, because once endosteum will come covering the cranial cavity, then what will happen? At the base of the skull, we are having some foramen, and at this level, foramen, it will ultimately continuous with the your periosteum or outer covering of the skull bone and other cranial foramina. In the base of the skull, there are so many foramen. When you see the base, that foramen magnum larger, then your foramen ovale, foramen spinosum, then your jugular, so many foramen cavities are there, openings. Then inner meningeal layer, that is inner to our periosteal layer. Inner meningeal layer, it is close contact with the arachnoid matter. Because arachnoid is there, beneath that we are having the arachnoid layer. So it is closely contact to the arachnoid layer or arachnoid matter and is continuous with the spinal dura. See, I have said in the spinal cord, it is covered by a single layer of dura matter. But in the brain, inside the cranial cavity, it is covered by 2 layers of dura matter. So what will happen? Endosteal layer, it is continuous with the periosteum of the skull bone, outer layer, at the level of the foramen magnum. Now what remain? Only 1 layer remain, which will go down to cover the spinal cord. That is our meningeal layer only. So meningeal layer covers the your outer, just outer to the arachnoid matter, and it is continuous inferiorly at the level of the foramen magnum to become the spinal dura matter. Okay, 2 layers fused with each other. Both the cranial, in the cranial dura, both the layer, periosteal layer or endocranium and the inner layer, inner meningeal layer, both are intimately attached or adhered. Only at certain region they get dilated, and these are known as a cranial venous sinuses. It is not the maxillary sinus. Maxillary sinus is different, then frontal sinus is different, and this is different. In this sinus, venous blood is there. But in sinuses inside the bone, your air is there. So difference, this is a venous sinuses, not air sinuses. Mind it. Now meningeal layer. Meningeal layer of the dura folded on itself to form some partitions. What will happen? This meningeal layer, because endosteal layer, here you see, these are 2 cerebral hemispheres. On the right side one, on the left side one. These are 2 cerebral hemispheres, and these 2 cerebral hemispheres are get separated by a fissure, by a gap. Okay. Now what happened? Here you see this your dura mater. This dura mater is going down, or it is going inside. It is going inside. Means between the 2 cerebral hemispheres it goes down. Okay. Form a partition. Between the 2 cerebral hemispheres, it forms a partitions. So meningeal layer of dura fold on itself to form some partitions, and which divides the cranial cavity into some compartment to lodge different parts of our brain. So what are the folds? Larger fold is falx cerebri. Falx cerebri, it is between the 2 cerebral hemispheres. 2 cerebral hemisphere, dura will come, then it goes down, then it comes up, then again it covers the left side. So what will happen? There is a partition that is called falx cerebri. Tentorium cerebelli, it is a tent-like structure, just a tent. Between whom? Cerebral hemisphere, then your cerebellum. Okay, cerebellum. So cerebellum and cerebral hemisphere, they are separated by tentorium cerebelli. Then falx cerebelli. Falx cerebelli, it is between the 2 cerebral hemisphere, cerebellar hemisphere, cerebellar and cerebral. Difference is there. So falx cerebelli, because our cerebellum is having 2 hemisphere, like our cerebral hemisphere. But thing is that cerebral hemisphere is larger, while cerebellum is smaller. So between 2 cerebellar hemisphere, there is a space, and that space is occupied by falx cerebelli. What is falx cerebelli? It is the fold of meningeal dura. Fold of meningeal layer of dura mater, which is present in between the 2 cerebellar hemisphere. Then there is diaphragm ocelli. Diaphragm ocelli is, if you have seen the base of the skull, then base of the skull, there is a one space at the center. That is called pituitary fossa. Now pituitary fossa, when this meningeal fold will go, thus it forms a roof. Suppose this is your space. Now what will happen? Meningeal layer will go like this way. It is form a roof. It is not going inside the bony cavity. So what will happen? It forms a roof. Inside that, beneath the roof, we are having the pituitary gland. So that is called diaphragm ocelli. In YouTube, you will get some animated video, so kindly you can see those things, okay, for better understanding. Though I have said here without any diagram or without anything, it is very difficult to imagine, I can understand. But you can see those videos and you will be able to understand. See here, I am giving one picture. So the larger one, just a sickle shape that is vertically present, that is our falx cerebri, between two cerebral hemisphere. Okay, one side is removed, skull bone is removed. Then you see one tent-like structure, that is tentorium cerebelli. So here cerebral hemisphere, and below that tentorium cerebelli we are having the cerebellum. Some faded structure at the midline just at the bottom line of your falx cerebri, you can see one sickle shape, another sickle shape where point is for your pointing, apex is pointing anteriorly. That is our falx cerebelli, because cerebellum is bit here. So falx cerebelli will be going from the posterior to anterior aspect. That is falx cerebelli between two cerebral hemispheres. At the center, you see that is a pituitary fossa, that infundibulum, where it is written as a infundibulum of the pituitary gland. So it is situated in a bony cavity, bony space, which is bridged by our meninges, that is our diaphragm ocelli. Okay, I am trying to give a brief idea in the picture. So if you will see the video, YouTube, then you can get. Then falx, sometimes these may come as a short note. Okay, meningeal dural fold. Describe about the meningeal dural fold. Or it may be a long question, or it may be short notes like falx cerebri, your falx cerebelli, tentorium cerebelli. Like that way, it may come as a short note also. So falx cerebri, it is a large sickle-shaped vertical fold of dura mater. It is vertically present, where dips into the longitudinal fissure, because between the two cerebral hemispheres, that fissure is called longitudinal fissure of cerebral hemisphere. So between the two cerebral hemisphere. So when it is going like this way, so it forms a sickle shape. It forms a sickle shape. So anterior end is narrow while attached to the crista galli. Crista galli is a bony prominent in our frontal bone, on the inner aspect of the frontal. Here you see that vertically it is coming anteriorly and attached to the crista galli. That is our crista galli. Here it is attached. Okay, so it is apex. This is our base. So base is attached to ultimately base is attached to our tentorium cerebelli at the midline. So it is a midline structure. Okay. So dips into the longitudinal fissure between the two cerebral hemisphere. Anterior end is narrow and attached to the crista galli. Crista galli is a bony prominence in the frontal bone on the inner aspect, while posterior end is broad. Posterior end is broad. Here it is posterior, so it is broad and attached to the upper surface, because tentorium cerebelli is here, so it will come like this way and it is attached to the tentorium cerebelli at the midline. So upper convex border attached to the vault of the skull along the sagittal suture. Now sagittal suture is your suture between the two frontal bone. Suture means your joining, fusion between there is a joint, suture. So it is attached to at the front, your sagittal suture. So upper border is convex. So upper border is convex and it is attached to the sagittal suture. Then lower border is free. Here you can see lower border, that lower border is get free. and concave downward. So upper border is convex, which is attached to the sagittal suture, while lower border is get free and it is concave and it get free. It is not attached to any structure. It is just hang. Encloses 3 dural venous sinuses. Now what is dural venous sinuses? These are the spaces between the 2 layers of the cranial dura. Because cranial dura is divided into 2 layers, but most of the your area of the skull inside the cranial cavity, they are fused together. But at certain area, they get detached. Now what will happen? This is a endosteal layer and this is a meningeal layer. Now it is covered. It is intimately adhered. Now if it gets detached, then what will happen? Ultimately there will be a space, and that space is called dural venous sinuses. Already I have said. Now these dural venous sinuses, it encloses, that is falx cerebri, because falx cerebri is coming like this way, then inferior border, superior border, then it is attached posteriorly to the tentorium cerebelli. So what will happen? It encloses 3 your venous sinuses. What are those? Superior sagittal sinus along the upper border. Here it is shown. This is your superior sagittal sinus. That blue line is. Here you see both the cranial dura, both the layer of the cranial dura is separated. And there is a space. Yes, this is your superior sagittal sinus. Then inferior sagittal sinus means along the inferior concave border also there is your space, that is your where the venous sinuses is present, inferior sagittal. One straight sinus where when it is posterior border is attached to the tentorium cerebelli, there also there is a space, they are occupying a sinus, venous sinus, that is called straight sinus. Then come to the tentorium cerebelli. Tentorium cerebelli, it is a tent-like semilunar fold. Why it is called semilunar? Because it is your semilunar. Okay, it is semilunar. Anteriorly free border, posteriorly it is get attached. Anterior border is free, while posterior border is attached to the bony margin. Now it is present between the cerebellum and the cerebellum will be below, and occipital lobe of the cerebral hemisphere above. So cerebrum is above, then our cerebellum is below. In between that there is a partition, and that partition is called tentorium cerebelli. This partition is made up of what? It is the fold of dura mater. So it is tentorium cerebelli. So it is having an outer convex border. So outer convex border, it will attach to the bone. You just imagine your occipital bone. Occipital bone inner surface is concave. Now what will happen? When this concave area some structure is attached, that structure will be what? It will be convex, definitely. It will have to attach here. So outer convex border and inner concave free border. Because attached border is attached to the bone, free border is free. Because our medulla oblongata will have to come through this free border. Now on each side, anterior half of the outer attached border, what will happen? On anterior, your attached border is there, anterior half. So on each side, our anterior half of the outer border attached to the anterolateral to the petrous part of the temporal bone, superior border of the petrous part of the temporal bone. Petrous part, where it is our inside the petrous part, our middle ear and inner ears are present. Okay, so it is lying your anteroposteriorly. So anterior half of the attached border is attached to the superior border of the petrous part of the temporal bone, while posterior border will attach to the occipital bone. Okay, posterior border is attached to the occipital bone, that is our leaves of transverse sulcus. Okay. Now what will happen when it is attached to the anterior half is attached to the superior border of the petrous part of the temporal bone, then it goes anteriorly and ultimately attached to the posterior clinoid process. Posterior clinoid process is present just posterior to our your pituitary fossa. pituitary fossa. There is a bony spike, actually, nothing else. This is a bony spike. One is anteriorly, one is posteriorly. So posterior glenoid process, anterior glenoid process. So it will come and it will attach here. Free attached border is your superior petrocell border of the petrocell bone. Then it will attach to your posterior glenoid process. Then your inner border is free, U-shape, but anteriorly it is attached to the anterior glenoid process. So anteriorly it will go and attach to the anterior glenoid process. So there is a crossing. Your posterior border attached to the posterior glenoid process, anterior border is attached to the anterior glenoid process. Now what will happen? Superior petrocell sinus remain along the anterior half of the attached border. When it is attached, this dura is attached to the superior petrocell bone, there is a space between the endosteal layer and the meningeal layer of the dura mater. So along this superior border of the petrous part of the temple, where our superior petrocell sinus is present. Now along this transverse border, that is posterior half of our posterior border of the tentorium cerebelli, there also sinus is present along this posterior border. That is called transverse sinus. Then come to the falx cerebelli. So falx cerebelli, it is a small sickle-shaped fold of dura mater. Then intervenes between the two cerebellar hemisphere. It is also anteroposteriorly it is present, but it is between two cerebellar hemisphere. Okay, so it is beneath the tentorium cerebelli. While above the tentorium cerebelli, we are having your falx cerebri. While falx cerebelli, it is beneath the tentorium cerebelli, between the two cerebral hemisphere. So you are attached to the internal occipital crest. On the occipital bone outer aspect we are having the external occipital crest, while inside we are having the internal occipital crest and encloses the occipital venous sinus. Then your diaphragm celli. Diaphragm celli, it is a small circular fold of dura mater which forms the roof of the pituitary fossa. Already I have said it, in the roof it is forming a roof in the pituitary fossa, and there is an aperture opening through which the stalk of the pituitary gland comes out. Okay. Now come to the arterial supply of the meninges. Meninges means which meninges? Dura. Only I am telling about the dura, so it is your dura come. So arterial supply to the dura mater, it is your anterior meningeal arteries, which are branches of ethmoidal artery. It is for anterior cranial fossa. So already I have said this, due to the dural fold, this inside the cranial cavity is divided into three parts: anterior cranial fossa, middle cranial fossa, posterior cranial fossa. Now anterior cranial structure which are present in the anterior cranial fossa, mostly it is supplied by anterior meningeal artery, which is your branches of ethmoidal artery. Then come to the middle meningeal artery, these branches of maxillary artery, it is larger in size actually, and accessory meningeal artery, it is these two arteries, that is middle meningeal artery, branch of maxillary. Along with that, another accessory meningeal artery which is going to supply the dura mater, which is present in the middle cranial fossa. Okay, anterior meningeal artery, branch of ethmoidal artery, supply the dura mater of anterior cranial fossa. Then posterior meningeal artery, which is a terminal branch of the ascending pharyngeal artery, and other small meningeal branches for the dura mater, which is present in the posterior cranial fossa. All these three arteries are mostly small in size, but out of these three, middle meningeal artery is larger in size. Okay, and it supplies most of the, because middle cranial fossa is more larger than the posterior and anterior cranial fossa. Come to the nerve supply of the meninges. So nerve supply, that is nerve supply means your innervation, that is sensory, mainly sensory. Sensory or by small meningeal branches of all the three division of trigeminal. So anterior, there are three branches division, that is maxillary, mandibular and ophthalmic division. So anterior cranial fossa, these are anterior, that means dura of the anterior cranial fossa, it is supplied by the meningeal branches. That means it is going to supply the meninges also, that is why it is called meningeal branches, which arises from the ethmoidal nerve. Ethmoidal is ultimately branch of what? It is an ophthalmic division of trigeminal nerve, which is denoted as a V5, V1. V1 means 5 actually, it is 5-1. Supply the floor and the anterior part of the falx cerebri also. Because anterior part of the falx cerebri, it remains in the anterior cranial fossa. Then another meningeal branches, that is ophthalmic nerve, that is runs posteriorly and supply the tentorium cerebelli also. Apart from anterior cranial fossa, what will happen? Another branch will go from the ophthalmic division and go posteriorly and ultimately supply to the posterior part of the falx cerebri. So ultimately, falx cerebri is supplied by our ophthalmic division of meningeal or meningeal branch, which is the ultimate branch of trigeminal. Then middle cranial fossa. So middle cranial fossa is supplied by your middle cranial fossa, medial and lateral is there. So medially by the meningeal branches from the maxillary division, and laterally by along the distribution of the middle meningeal artery. So that means some branches are going along with the middle meningeal artery. So these are by the meningeal branches from the mandibular. So you can remember it simply that medial part of the dura of the middle cranial fossa is supplied by maxillary nerve, while lateral part of the dura mater of the middle cranial fossa is supplied by mandibular nerve. Both are division of trigeminal. Then posterior cranial fossa, come to the posterior aspect, it is mostly supplied by meningeal branches from first and second cervical. Sometimes third cervical may also contribute to the posterior cranial fossa. So what will happen is that if we are having your spondylisis, cervical spondylisis, then what will happen? Our bones are having some erode and bones will get damaged, and ultimately your spinal nerves, cervical spinal nerve will get compressed or get irritated. Then what will happen? Patient will come with a history of, patient will not say that I am suffering from cervical spondylitis. What patient will say? I am having severe headache in the posterior aspect, and which is radiating to every side, all the sides of the posterior aspect of our skull. Then patient may think that he is or she is suffering from hypertension, because this is a common that during hypertension only we are having a headache. So your headache due to hypertension and headache due to your spondylitis, it will be different, because in case of hypertension, headache will be all around the skull. But in case of cervical spondylitis, it is mainly confined in the posterior cranial fossa. That is why it is more confined in the posterior aspect of the skull. Okay. Then come to the arachnoid. So dura, we have discussed what is dura, dural fold, then dural venous sinuses. Then we have discussed about the arterial supply, venous supply. Okay. Now come to the your arachnoid matter. So arachnoid is the next layer. Inner to the dura matter, we are having the arachnoid. So it is thin but avascular membranous structure. It is not adhere to the dura and not adhere to the pia also. So above your arachnoid matter, we are having a space that is called subdural space, and below the arachnoid we are having a space which gets separated from the pia matter, that is called subarachnoid space. In the subdural space, mostly it is occupied by cerebral vein. Okay, subdural means above the arachnoid. Then arachnoid villi. What is arachnoid villi? Definitely villi means it is a structure. Villi is your finger-like projection. So it is a small finger-like projections of arachnoid tissue. So arachnoid matter which will go up. Okay, finger-like projections. Here you can see this green structure is our outer green line is our arachnoid matter. Now it is going above, just a finger-like projection. These are where it is written as a granulation, arachnoid granulation. So you just think of for some time that these finger-like projections are arachnoid villi. From this arachnoid villi, when it gets enlarged in size, then we call it is arachnoid granulation. Okay, so granulation is the last stage of the villi. So small finger-like projection of arachnoid tissue projecting into the cranial venous, dural venous sinuses. Here you see it is extending to the dural venous sinuses. Now it absorbs the CSF. Where our CSF is present in the subdural space, subarachnoid space. Now what happened here? You see subarachnoid space, ultimately subarachnoid space and dural venous sinus, it is get communicated by whom? By our arachnoid villi. Now in the subarachnoid space, that is the green line and the red line, between the green and red, red line is our pyometer and green line is our arachnoid meter. In between that, this is a space, that space is your subarachnoid space. In the subarachnoid space, we are having the CSF. Now this CSF, if it is accumulated in the subarachnoid space, then what will happen? Ultimately, it will compress the brain tissue. So it will have to drain out. Now how it will drain out? By other route is also there, but this is another route. This by means of this arachnoid villi, it is going to where? It is going to your subdural venous sinus. Now through these villi, ultimately some amount of CSF will drain into our dural venous sinuses. That means it will ultimately draining into our venous system, because this dural venous sinuses ultimately comes out and drain into our jugular venous system. So it absorbs the CSF. As age advances, that arachnoid villi enlarge in size to form pedunculated tuft, which is known as a arachnoid granulation. So villi ultimately, as the age advances, it will enlarge in size. And these arachnoid villi, what may do? So these arachnoid villi, when it get enlarged, now in the picture, if you see, this is our in the sagittal suture. This is our sagittal suture. This in the sagittal suture only it is going towards the sagittal suture, and ultimately it will form some erode. It makes some impression over the inner aspect of the cranial bone, particularly in our frontal bone. Sorry, parietal bone. Okay. Then come to the pyometer. So pyometer, it is thin, delicate membrane. It closely invests the surface of the brain. So it intimately covers the brain tissue. And it follows the contour of the brain, because brain, it is not your uniform structure, uniform surface. It is having some convolution, it's some depression and elevation. So pyometer will go inside the depression, then again it covers the elevation, then again go inside, then again comes out. Okay, so it intimately covers the brain tissue. So entering the grooves and fissures on its surface. So closely applied to the roots of the cranial nerve. From the brain, cranial nerves comes out. Now these cranial nerves are also covered by pyometer. When it comes out, it pulls the part of the pyometer along with the cranial nerve and provides the seat for the cranial nerve by means of pyometer. Now folds of pyometer enclosing as a tuft of capillaries, so which are known as a plexus, choroid plexus or tela choroidea. These are actually, suppose pyometer is going, then again it comes back, so it is having a fold. At certain region it is forming a fold. There is a suppose cavity, one cavity is here, so this is a roof, this is floor. Now what will happen? Pyometer will go inside, then it comes back, it forms a fold. Now as it forms a fold, inside the fold some blood vessels will be present, and that capillary plexus is called choroid plexus. Choroid plexus is the capillary plexus. When it is present in your ventricular system, then we call it is tela choroidea. Now come to the arrangement of meninges and space. Space, what I have said, subdural space, subarachnoid space. It is the extradural space. Now where is this extradural? It is a potential space related to the durameter. It is extradural, so it is outer to the durameter. So this is a potential space between your dura and your skull bone. So outer or periosteal layer of the durameter is firmly attached to the bones and the surrounding the cranial cavity. Then resulting is that there is a potential space between these two structures, and this potential space becomes fluid filled, having some amount of fluid. So this when there is a trauma in the skull, then what will happen? The blood vessels will get ruptured, and this blood will accumulate in the extradural space. And due to this extradural space, what will happen? Brain tissue is not injured. Only your veins are get injured, then veins will damage, and in the extradural space there will be accumulation of the venous blood, and due to this accumulation of the venous blood in the extradural space, it will compress the brain and ultimately patient will suffer. But once we do just remove the blood, venous blood from this extradural space, what will happen? That compression will remove and ultimately patient will immediately get relief from the problems. And mostly what will happen, what venous blood is accumulated, these are meningeal artery or blood from the meningeal due to the rupture of the meninge, because meningeal artery is supplying to the meninges. So these meningeal artery may get ruptured due to the injury to the skull, or it may be dural venous sinus, the rupture of the dural venous sinus. So what will happen? Ultimately collection of blood in between your two layers of the dura mater, that is extradural space, and which is also known as a extradural hematoma. Subdural space is the capillary space between the dura and the arachnoid mater. So it is beneath the dura mater, between dura and arachnoid. It is a very small space. Space is comparatively very small. So contains again thin film of fluid. Otherwise, what will happen? These two layers cannot move to make frictionless movement between the dura and the arachnoid. Then subarachnoid space, that is space deep to the arachnoid mater, between the arachnoid and the pia mater, which surrounds the brain as well as the spinal cord where our CSF is present. In certain area, what will happen? This subarachnoid space get dilated, and which are known as a subarachnoid cistern. It may again comes as a short note. Short notes also and a long question also, because subarachnoid cistern, it is a difference here, it will be different class. Then it contains CSF as well as blood vessels. Then I am just mentioning here, but it may be a separate class. Okay. So cistern. So cisterns, what is cistern? These are dilatation of the subarachnoid space which is present around the space. Normally it is, suppose I am just giving example, that space is 2 centimeter, but in certain region it becomes 20 centimeter. Space is 20 centimeter diameter, so it gets dilated. Then it is called as a cistern. Now there are cistern. Why actually this cistern will present? Because of it is present between the pia and the arachnoid mater. Pia is closely invest the structure. Suppose this is my brain. Just you think that this is my cerebral hemisphere and this is my medulla oblongata and pons. Okay. Now what will happen? Pia will come, then pia will cover like this way. Now what happen? Arachnoid mater, it will come, goes like this way, then it will breathing. What will happen? There is a space between the pia and the arachnoid. Now what happened? This subarachnoid space get dilated. Is it or not? Can you get my point? Can you get my point? Sound is off.
Sir.
Can you get my point?
Sir.
Why this cistern is forming? If this is my cerebral hemisphere and this is my medulla oblongata, the brain stem, then what will happen? Pia will come, intimately cover the brain surface, then it will intimately cover, but arachnoid is not going to cover intimately. So what will happen? This is a pia and this is arachnoid. So what will happen? There is your dilatation. The subarachnoid space get dilated. Okay, and these are known as a cistern. So at certain region where this cistern we will find cerebellomedullary cistern. Name is telling you cerebellomedullary. That means it is between the cerebellum and medulla. There is a space which is called cerebellomedullary cistern. So it is posterior to the medulla and inferior to the cerebellar hemisphere. Suppose this is the medulla oblongata, this is the cerebral hemisphere. So posterior to the medulla and inferior to the cerebellum. So this is called cerebellomedullary cistern. What it receives? It receives CSF. Because in the subarachnoid space, your CSF is present. Now this CSF is coming from where? This CSF is coming from the fourth ventricle. Now, where is the fourth ventricle? Between the medulla and the cerebellum. Already I have said. Yes? So, by means of a apparatus in the medulla, the fourth ventricle, we are having a apparatus at the midline, that is your median apparatus, which is called mesendi, and laterally we are having foramen lasca. Already you know this thing in your class 12, I know. So, it ultimately is CSF, which is coming to the fourth ventricle. From the fourth ventricle, it will go to your subarachnoid space. Which subarachnoid space? That is our at the region of the cerebellomedullary cistern. By means of whom? That is your foramen of mesendi or median apparatus in the roof of the fourth ventricle. What it contains in the cerebellomedullary cistern? Vertebral artery, which is supplying to the brain. So, vertebral artery and posterior inferior cerebellar branch. Okay. Then you come to the pontine cistern. So, again in the pontine, that means it is related to somehow at the region of the pons. So, between the pons and the clavus. Now, what is clavus again? Clavus is a part of the bone. Okay, part of the bone anteriorly, and pons will be posteriorly. So, this between the pons and the clavus, here we are having the pontine cistern. The cerebellomedullary cistern above, interpedunculaar cistern below. Okay, interpedunculaar means interpedunculaar will be at the level of your pituitary fossa. It will come to the pituitary fossa. I will come. So, your pontine cistern, cerebellomedullary cistern will lie above. Then interpedunculaar cistern will be below. In between that two, we are having the pontine cistern. What it contains? It contains basilar artery as well as your branches, associated branches, which is arising from the basilar artery. Interpedunculaar cistern, it contains the circulum willis, that is at the base of the brain. Not at the base of the skull, but base of the brain. At the base of the brain, if you see the base of the brain picture, then you can see that your anteriorly we are having the frontal lobe, posteriorly we are having the occipital lobe, and laterally we are having the temporal pole. So, in between that there is a area gap. One depression is there, one depressed area is there, and that is called interpeduncular region. And at that interpeduncular region, because pia will go inside, while the arachnoid matter will not go inside, so there will be dilatation. And at that dilatation, that is the interpeduncular cistern, we are having the circulum willis, which ultimately supply to the brain. Complete brain is supplied by circulum willis. Then cistern of lateral sulcus. Lateral sulcus here along the lateral surface of on the lateral surface of the cerebral hemisphere, we are having a sulcus. Sulcus and gyra, it will be discussed differently. So, along this lateral sulcus, we are having a middle cerebral artery, where cerebral here there is a dilatation of the subarachnoid space. That is called cistern of lateral sulcus. Then cistern of great cerebral vein or cisterna ambiens. That is contains the great cerebral vein. Then cisterna chiasma. Cisterna chiasma, it is just at the base of the skull. Base of the skull, because at the base of the skull our pituitary fossa, then we are having the optic chiasma in the interpeduncular fossa. Then at that region there is your dilatation of the subarachnoid space, which lies below and in front of the optic chiasma. And arterial pulsation within this cistern helps in the circulation of the CSF all around the brain. This part you see in the book as well as in the pictures in YouTube. At least you can understand better. Then meninges part is over. Then come to CSF. Now communication of the subarachnoid space. So this subarachnoid space is get communicated with the ventricular system of the brain, because ventricular system already I have told. Now subarachnoid space is a different space, and ventricle is a closed, actually tubular structure. Now this closed tubular structure and our subarachnoid space get communicated at certain region. Where it is get communicated? By means of a median foramen, that is of foramen of Meninges. Then lateral foramen, that is foramen of Lasca, where it is related to the fourth ventricle. Then CSF passes through these foramina, that is Meninges and Lasca. Then it is from the ventricle it goes, because CSF is mostly produced in the ventricle. Now from the ventricle it will come out to the subarachnoid space through this foramen of Lasca and Meninges. Then come to CSF. What is CSF? It is modified tissue fluid produced in the ventricular system of the brain, remain in the subarachnoid space, already I have said, of brain as well as the spinal cord. CSF replace here the lymph, because no lymph node or lymphatics is present in the brain central nervous system. Instead of lymphatic system, we are having the CSF. Okay. Then formation, how it is formed? It is formed by a process of secretion. Already you know this word. That mostly formed by choroid plexus. What is choroid plexus? These are the tuft of capillaries in the fold of the pyometer of lateral ventricle. Then here partly by the third and fourth ventricle. Total quantity is our 150 ml. Then rate of formation is 200 ml per hour. So if you multiply by 24, that means it will come around your 4800. That means 4 liter, almost 5 liter in a day. But it is only total quantity remains 150. So where this other amount go? In case of your urination, we get toilet and we go toilet and we just evacuate our bladder. But here there is no system like this. So 5 liter is produced, only 150 ml remain around our CNS. So where others go? It is through our arachnoid villi, it is draining into the dural venous sinuses. Okay. So normal pressure of CSF, it is your 8 to 15 millimeter of mercury. Suppose if this pressure is increased, what will happen? It will compress our brain tissue. Then our function will get deteriorated. Okay? To maintain the pressure, we have to evacuate the CSF. Now from your formation of CSF in the lateral ventricle, then through foramen of Monroe, come to the lateral third ventricle. From the third ventricle, aqueduct of Sylvius is there. Through the aqueduct of Sylvius, it come to the fourth ventricle. From the fourth ventricle, by means of foramen of Meninges and Lasca, it will go to the cisterna magna and cisterna lateralis. Then it is remain in the subarachnoid space. From the subarachnoid space, it goes to the spinal cord. As it remains around the spinal cord and as well as it remains around the cerebral hemisphere. So this is this blue structure is our ventricular system, and lateral ventricle, the larger part is lateral ventricle. That one is written, this is your third ventricle, communication between the lateral and third ventricle by means of foramen of Monroe. Then structure 2 is an elongated structure, vertically comes to communicate with your third ventricle. That communication is called aqueduct of Sylvius. Then your fourth ventricle, in between the cerebellum and the pons, that's where it is written 3, that is your cisterna magna. Ultimately it is draining into the cisterna magna by means of your foramen of Meninges and Lasca. So absorption of CSF mostly absorbed by the arachnoid villi into the dural venous sinuses and spinal veins. Small amount is absorbed along your perineural space into cervical lymphatics, because around the spinal cord we are having some amount of lymphatic vessel, because other structure is also there, your bone is there, then muscle is there, so some lymphatics are there, so some amount is also draining into the cervical lymphatics and into the perivascular spaces, which is mostly around the spinal cord only, not inside the cranial cavity. Normally 500 ml of CSF is formed. This is not 500, actually it should be 5000 ml. ml is formed every day and equal amount is almost absorbed. Then what is the function of CSF? It is protective. How it is protecting? It acts as a shock absorber. This CSF acts as a shock absorber. Otherwise, what will happen? When we suddenly some jerky movement is produced, what will happen? This brain will ultimately directly hit on the cranial bone and ultimately brain will get damaged. So when you're around the brain, we are having a watery fluid, which is ultimately that CSF will stuck over the or just strike over the bone. So your brain tissue is not actually injured. Okay, that is protective, nutritive, because it gives some amount of your electrolytes. Then pathway for exchange of material between blood and brain tissue. Then applied anatomy, that is lumbar puncture. When there is suppose if there is an infection in the meninges or the brain, then what will be meningitis? We call it as meningitis. Then if there is a meningitis, what will happen ultimately in the subarachnoid space fluid? That is subarachnoid, your CSF, your lymphocyte count will increase or neutrophil count will increase, some bacteria may get present in the CSFs. Then what we will do? We do the lumbar puncture. At the lumbar vertebra, we just in between the two lumbar vertebra, we penetrate a needle, that is called lumbar puncture. Then we enter into the subarachnoid space, then we withdraw some amount of fluid for diagnosis purpose. Then cisternal puncture also we can do, that is at the cistern. Mostly it is done in case of newborn baby. Then ventricular puncture, that is inside the ventricle. Suppose what happened, there communication between the ventricle and the subarachnoid space, if it is obstructed, what will happen? It will be more fluid will be accumulated in the ventricular system and ultimately it will compress the brain tissue. Then what will happen? We do the ventricular puncture. We put a drainage tube in the ventricular system and we try to drain out. Mostly these are done in case of infant or newborn baby. Hydrocephalus means if the amount of CSF is going increase, that is called hydrocephalus. Then what will happen? Increase in volume of CSF means increased pressure in the CSF within the skull, and there will be intense headache for the it is, and also your brain's function will deteriorate. Okay, thank you.
Thank you, sir.